Olá a todos, meu nome é Fabio Tavora, eu sou médico patologista aqui no Laboratório Argos, em Fortaleza, e também trabalho no Hospital do Coração Dr. Carlos Alberto Estudas de Gomes, em Messejana. Sou membro da Sociedade Brasileira de Patologia e conversei há 2 dias com o Dr. Angelo Pan. O Dr. Angelo é médico infectologista e chefe da divisão de infectologia do Hospital de Cremona, na Itália, ao norte da Itália. E lá é uma das regiões mais atingidas pelo Covid-19. O Dr. Angelo foi bastante solícito em compartilhar suas informações e experiências, e essa entrevista tem como objetivo melhorar nosso entendimento sobre essa epidemia e para que a gente aprenda com seus erros e também com seus acertos. Eu vou compartilhar essa entrevista em 4 vídeos separados e, de modo algum, ela constitui recomendação médica. É apenas uma entrevista e troca de experiências com um especialista em infectologia para que a gente possa entender melhor o que está se passando. Ele tem trabalhado com uma equipe médica dedicada e, mesmo assim, foi castigado com um número enorme de pacientes graves que tem aumentado dia a dia. A entrevista tem alguns pontos bem técnicos e eu peço desculpas por isso, mas também outros bem pessoais, quando ele, por exemplo, ele compartilha com a gente que perdeu um amigo médico 2 dias antes da entrevista. Por fim, eu queria pedir desculpa pelos erros em inglês, erros como entrevistador, já que essa não é minha prática diária, mas espero que esse vídeo e a conversa com o Dr. Angelo possa ser de benefício para nós médicos e para a gente entender a epidemia do Covid. Também participou da entrevista o Dr. Isacco Ferranrini, médico hematologista em Verona, na Itália também, e no final do vídeo ele faz também algumas perguntas ao Dr. Angelo. Então, sem mais delongas, eu lhes apresento a entrevista com o Dr. Angelo Pan, em Cremona, na Itália. Muito obrigado. So, Angelo, thank you so much again on behalf of the society. We are very appreciative of your time. I know your time is very short, so please let me know whenever you want to finish this. Can you tell us a little bit about how was your life a month ago, and how's your life now in daily, and what's happening right now in northern Italy?
Yeah, well, I'm an infectious disease doctor, and my main research area is antimicrobial resistance, and we were struggling to control KPC, Klebsiella pneumoniae is producing. We are working hard on that field because we have a bad problem regarding KPC in Italy. We were worried, of course, about the COVID outbreak in China, and let's say from the 10th to the 20th of February, we admitted 6 patients with the suspected COVID infection because they were arriving from China and had fever. They were screened for coronavirus, other respiratory viruses, and they were all negative. We had a nice protocol that was ready exactly that on the 21st of February in the morning, saying that if one patient arrived, we would have put him in a special room in the casualty room, and then we had a track that it should have followed, being admitted to one special room, one dedicated room in our ward. And so we had a very nice thing for one patient, and maybe in the unlikely events of having 2 patients together, we would have put them in the same room.
So at that time, you didn't have any test for coronavirus, I assume. You only tested for H1N1?
We had tests ongoing from the 10th of February. We sent them to the viral unit of the University of Pavia. So we didn't have them not homemade. We didn't have it inside, but we had them to send them outside. On the 21st of February, on the 20th of February, there was a case in Codogno. Codogno is a small city, about 20,000 inhabitants, about 25 kilometers from Cremona. And on the 21st, we had our first diagnosis, a lady that was admitted on the 19th, and the with bilateral pneumonia, interstitial, and she was diagnosed on the 21st. The result arrived on the 21st, and thereafter, starting on the afternoon on the 21st, we kept on had patients arriving at the hospital with pneumonia. The first night I was on call. We opened a special extra on-call ward, and it was me, since I was an infectious disease doctor available at that moment, who took care of the night, and we had 14 patients admitted that night. I worked all night, just one admission right after the other, and it went on like this for the following day. We had to open a special unit for COVID the next morning on the 22nd. No, just the 21st was the first day. The 22nd we opened another unit.
Okay, I see.
The following day, and then the next day we doubled. Our unit has 12 beds, and we transformed into a 44 beds unit.
Okay.
So that was on the 24th.
Yes.
Or the 3rd. Anyway, I don't remember exactly, but in the next few days we opened one ward every day, because we had like 30 to 50 to 60 patients arriving every day at the casualty room with pneumonia.
So do you believe this first spread was all community-based, or do you think there was also some spread within the healthcare services, the primary care services and the hospitals?
A few were hospital-based, but most of them were community-based.
Okay.
Let's say I can say probably 10%. I have not looked exactly at the data because we've had so much work to do. But let's say my feeling is about 10% is healthcare associated, and the rest 90% is community acquired.
Okay. And these patients are arriving at your department. If you could describe the typical patient.
Now, the thing has been changing over the days. In the very first days, the patients were arriving with mild disease and were worsening over the following days. Now we get when they arrive to the casualty room, they are progressively more severe. We have less patients, but more severe patients in these days over the last week, let's say. What happens usually, the natural history of the disease is that they start with low-grade fever. The fever increases like 37.2, 37.5 over the first 3-4 days, and it increases up to 38, 39, and patients usually arrive to the hospital after 7 to 10 days, maybe a bit more. And by the time they arrive to the hospital, they have almost all of them, they have respiratory failure with saturation that is below 95, and sometimes is much lower. The elderly are hit bad by this disease, and the mortality is quite high among elderly.
If you could estimate the number of patients in your hospital, how many are in the ICU and how many are in the typical wards with CPAP or other known measures?
The hospital has completely changed its face over this last month. Our hospital has 550 beds, and we have all the different units. We do not have transplantation. We only have autologous bone marrow transplantation. We don't have any solid organ transplantation. We don't have cardiac surgery. We have neurosurgery. So it's a second level hospital with different numbers of the different wards. Now, and we had 12 beds of infectious disease in the infectious disease ward. Now we have 500 patients with COVID, pneumonia. Okay. Our ICU has 8 beds normally with +2 emergency beds. Now our ICU has 40 beds plus 8 in the hospital, in the field hospital that we have in the American field hospital that was opened last week here, the Samaritan Purse that opened the field hospital to help us. So now we have 48 beds of ICU. We had to close our operating theaters to open beds with the ventilators that we had available over there. Normally we have 6 patients on CPAP.
Okay.
Now we have about 90.
Okay.
And because most of the patients now are let's say they arrive when we are happy when they have intermediate ARDS. So we feel comfortable when they have intermediate ARDS. If they have severe ARDS, we put them, either we intubate them if they're young, and if they're not too young, we go for CPAP. And so we have about, I would say, 90 patients. Altogether, we have about 140 patients. That is about a bit more than 1/4 of all the patients inside the hospital with pneumonia, with COVID pneumonia, ventilated.
So the choice of using CPAP in older elderly people is more because of the lack of resources, or is there any specific protocol for that?
No, there is not a protocol, although I don't know if the WHO guidelines say that it's better to intubate them, but I'm not sure that we have data regarding intubation of elderly people. So I guess that CPAP probably is better. We have data to analyze, but CPAP, I don't feel it's too good to just go for intubation in people in their 80s or 90s. Probably CPAP is a better option.
Okay. And comparing to the other ARDS patients that we've been seeing for many years from different causes, what do you think is specifically being done to these patients? I heard some reports about the prone position, some reports about using some different drugs, not using steroids or using a lot of steroids. What do you think is more specific about these patients with coronavirus infections?
Well, specific is the duration of intubation. Unfortunately, they have to be intubated for a long period of time. That is a big problem because you stock up the ICU. You cannot. I mean, they are intubated for 2, 3, 4 weeks, and it's very difficult to wean them from the intubation. So that's a problem within the problem. It's not that with 3 days of intubation you can just take it off and bring them back to a normal ward. This is point one. Well, regarding the steroid use, we use them when we have intermediate or severe ARDS. The literature is not very clear-cut on this side, but we follow this internal rule, and we have regional guidelines regarding the use of steroids. We use dexamethasone. The Chinese have used methylprednisolone, but we prefer to use dexamethasone based on a paper that was published by the Spanish
but not high doses, low doses.
We use 16 to 24 milligrams of dexamethasone depending on the weight, for 5 days, and then we half the dose for another 5 days.
Okay. And many of these patients do have superimposed infection or not? Bacterial infection?
No, I haven't. We started using antibiotics for everybody, but then now we don't use them anymore. We may use azithromycin associated with hydroxychloroquine because it looks that it may reduce viral load, and it may help with anti-inflammatory effect in treating the patients. But we use antibiotics only in patients that have superimposed infections, and they're relatively rare. I mean, it's not a common event.
Okay, and the azithromycin plus chloroquine, of course, the whole world is talking about it. There are some ongoing clinical trials, but still, we see a lot of patients dying every day in Spain, in Italy, in New York City. Do you think it's how do you think it's the effectiveness of this combination?
I don't think we have a straightforward effect. I mean, there is not a drug that acts like antibiotics for sepsis. No such a thing. You start these drugs and the patient, if I get informed by the doctor or the patient themselves at home, I generally, even it's not formalized yet, I generally recommend to start hydroxychloroquine and azithromycin at home at the very beginning of the symptoms. So what I hope to do is just to cut down the viral replication if it's possible, and to limit the evolution in ARDS. That's my hope. In ICU, they get some of them get multi-organ failure. Before the ICU, it's not very common. I take care of patients in the normal ward. We take care of about 70 patients in the infectious disease ward now, and we don't see too many either. Renal failure or hepatic failure, or even transaminases increase. It's not very common.
Okay, everybody's talking about system collapse everywhere. I mean, in Brazil we have a not very good medical system. We divide in public and private, but I think we can divide the collapse in between patient care and also medical staff.
We are still okay. We started with the disease very early. We were the first hospital with Codogno, so we started on the very beginning of this epidemic. So we are our system is getting PPIs everywhere, and they are very smart and they know where to get it. They've been reaching for PPE everywhere. So we have not any problem yet to get these devices. What happens that is even worse than not having PPEs is the doctors and nurses, healthcare workers get infection. Right. So you really need to, if you have PPEs, you really do need to use them correctly. And what is fundamental, in my opinion, is to educate everybody to the correct use of PPEs and to doffing, and to hand washing. Hand hygiene is of absolutely primary importance, because you may feel safe using an N95 mask, but if you don't wash your hands, you will get the infection, because it's droplet and contact is much easier probably.
So do you have an idea how many healthcare workers in your hospital got infected, and the ones that are not infected, are they going home every day? How's the typical day for your staff right now?
Well, nurses have their standard shifts, maybe a bit longer because the patients are harder, and they do not complain regarding longer shifts. They are working fantastically. Right. For doctors is a bit harder because we were a bit understaffed before, and now we are still understaffed, but with many more patients. We have a help from other doctors that came to work to our ward, but they are young doctors, so right. It's only for elderly, let's say elderly. If my colleagues, the female doctors listen to me, they will kill me. But people that has a good experienced doctor, it's only 4 of us. So one is at home because she got infected because her husband got infection. She did not get infection in the hospital. Okay. So it's 3 experienced doctor of us and 1 young doctor just graduated from infectious disease specialty 3 months ago. And we have other doctors that are either just graduated from medical school or in the specialty school. So okay. It's better than nothing, but you cannot just, although it's relatively simple because it's just one type of disease. You don't have to take care of meningitis, endocarditis, sepsis, and whatever. It's just COVID. but it's a very, very complex overall situation. So we are working hard, and my shifts generally, I work about 15 hours every day, and not all in the hospital, let's say 12 to 13 hours in the hospital, and then at home doing some extra work for emails, reading a little bit of literature.
Interviews and so.
Yeah, and yes, exactly. And I think it's important because it's not that I like too much to be on TVs and whatever, but I think that opportunity that I had with CNN to give information regarding what's going on, especially to the UK and US, where they're not taking this. I think they will rapidly change their mind in the US, but seeing what's happening here, our hospital has completely changed its face. It's like we are living in another planet. On another planet.
Right. I mean, it's a complete nightmare for the whole world. So we saw China, we saw Italy, we are seeing Madrid and New York. And I can tell you, some people in Brazil, even if some physicians that are friends of mine, think, oh, this is just fine. We are a hot, warm country. We won't have this disease. Can you give us a message of you're in the front lines?
Especially elderly people have to stay home. I mean, there is no way that they can go out because in our experience, mortality, not just being sick, but mortality in people over 80 is very high. So it's absolutely necessary that they do not get sick, and they have to stay home and absolutely comply with the indications. I don't see any other opportunity. I don't know if the high temperatures you have in Brazil will be a wall on COVID, but I would not like to try to see if it's true or not. I think it's better.
No, of course. You have increasing numbers and also some deaths. But tell me, just because we see in Milan, for example, there are maybe 3,000 deaths in a 10 million population. In Rome, 31 deaths. In Sicily, only 3 deaths or 6 deaths, I think. Just big numbers. So do you think it's just a matter of infection rate, or is there something special about the cities that are having more hospitals, more patient care, or just more infected people in the northern Italy that's going off this high death rate?
Yeah, I think right now it's a higher incidence of the disease in Lombardy and in the northern parts of the country. Okay. I really do hope that the southern part will be not involved in this pandemic, and I hope that the indications that have been done by the government on the 10th of March will be effective in reducing. We are seeing. I think it looks like we reached the top of the curve.
Right.
I really do hope so, and I hope it's going to be this way also in the other areas. The difference is striking, and I hope it will remain like this.
Right. Yeah, I mean, we looking about the curves in Brazil, we are about 20 days behind you, but it's almost the same curve. It's amazing how reproducible the curves measurements. So what kind of hacks, I'm sorry to use this word, are you using to treat multiple patients when you don't have enough resources?
Yeah, I think you have, if you have like everybody has a limited number of ventilators for the problem you have. A thing that was just put up in Bologna is that the thing that can give you the chance to use one ventilator to ventilate 2 people. Right. It splits the power of the machine for 2 patients, so you can double the number of patients that you can ventilate. We do not yet have this system, but I think it's going to be used in the future because we may need more ventilators. Even though if the pandemic, if the curve is going down, maybe we can just pass it over. I don't know. It depends very much on what's going to happen in Milan, because if Milan will be somehow controlled, we can survive it. If Milan will be involved badly, Milan has about the Milan area has about 3 million inhabitants. If it will be hit hardly, I guess we will receive plenty of patients from Milan, so we will need to increase our number of ventilators again.
I'm sorry, do you have any idea about herd immunity and reinfection? Do you believe it's after the patients are recovered, are they immune to the disease, or you don't have this information yet?
Don't have the information yet, no. Herd immunity, I don't know. Sorry, but I don't have time to read the literature.
Of course, no, because some people are already opening the borders. People are going to the streets in some countries, and we are afraid of having a second wave of infected people everywhere. So that's why I'm trying to ask this question.
The problem, I think I think we will be safe when we will have the vaccine. Otherwise, it's possible that we will have other waves of the as soon as you reopen everything. Waves of the infection. It's not only the elderly, because I had a friend of mine who died 3 days ago. He's an infectious disease doctor, and I was the director of a private hospital here in Cremona. I had 2 colleagues of mine, infectious disease doctor in Brescia, that were admitted to ICU, and they finally came out of the ICU. And a colleague of ours, our doctor of the hospital, is in the ICU right now. So they're all in their 60s. They're not 80s or 90s. And they're working.
I'm very sorry to hear that, yes.
Yeah, it's not just a problem that will affect the older ones. There are cases even among younger people, and even severe cases in patients that do not have underlying diseases, not only patients that have severe underlying diseases. So this has to be taken in serious account when you think about fighting the disease and taking and following the strict rule of isolation and reduction of contact.
And of course, the other diseases don't stop. We still have myocardial infarction, we have cancer patients, we have to take care of them, and we have to work in different hospitals to take care of the patients. I'm a pathologist, but we still receiving all these cancer biopsies to look at and treat cancer patients. So it's a very tough situation for all of us.
Yeah, very tough. I think from learning from our experience, a thing that should be put in place early is a collaboration with general practitioners, because it's probably better, and we don't have data yet, but my impression is that if you start treatment early, when fever starts, maybe you can reduce the risk. Hopefully, you could reduce the risk of evolution. We don't have data, but...
Wait, are you talking about chloroquine and azithromycin, or what kind of treatment?
Yeah, I mean, either hydroxychloroquine and azithromycin, or we use sometimes at home darunavir. We are out of lopinavir, ritonavir, and we keep on using protease inhibitors for HIV, despite the paper that was published in the New England Journal of Medicine a few days ago, because the paper is underpowered. Only 200 patients. There is anyway a reduction in mortality, is about 6%, a reduction in ARDS, a reduction in the days of duration of the disease. So these are all small things that do not define in a clear-cut way that it does not work. So even if it's small, a small advantage, I think we should go for it, and possibly start it earlier, and could be very interesting.
Right, especially if they decrease the viral load, and maybe, perhaps, we don't know, it may also decrease infection of other patients. So exactly, that'll be a good reason. Okay, we are very appreciative of your time. Thank you so much for talking to us. And do you have any final sentences to send to Brazil? And please share with us. Thank you. And we're all thinking about Italy here, and hoping for the best everywhere. Any final thoughts?
Final thought is that it's a real change of life. I've never thought it could have been this bad, and it's real bad. Our hospital now has more than 500 patients with pneumonia, COVID pneumonia, and about a fourth of them need ventilation. So it's nothing similar to anything I have seen before in my life, and I think it's nothing similar to anything that has been seen over the last century in this part of the world. We have not had such a pandemic since the Spanish flu in 1918.
Okay, thank you. Isacco, any other last thoughts, Professor?
Yes. A quick question, Angelo. I wanted to ask you if you have noticed a particularly severe clinical course in immunocompromised patients, or if the clinical course is similar to other patients. Did you ever notice any difference in the severity of clinical course?
No, we have not. I have not seen any particular immunocompromised patient. For example, not too many solid organ transplant patients were infected. Some of them are, but I do not have the impression that we only have immunocompromised patients. I could not have seen the part of patients that have solid organ transplantation, but for example, for HIV, we only had 2 patients admitted, 1 patient admitted and 1 at home, and they had a very rapid disease and went home rapidly. One stayed home and the other one went home. So I do not have the impression that immunocompromisation or immunocompromise is a high risk factor for this disease. Many younger people have some problems, and they're not like people in their 40s or 50s. They may be obese or may have some health problems. They're not in absolute health, but I do not have the impression that deep immunosuppression is a high risk factor. Please. Okay. It's an impression, so just take it as it may be.
Okay, yeah. So the final word is stay home, if possible. And who was healthcare? We thank you everybody, and let's get to work. Thank you so much, Professor.